Hello, and welcome to the Surgical Assistant Podcast, a podcast crafted by surgical assistants for surgical assistants, where professionalism meets passion.
Hello, everyone. Welcome to the Surgical Assistant Podcast. I'm Kelly.
And I'm John. Welcome back.
Hi, John. How are you today?
I am well. Thank you, Kelly. How about yourself?
Good. Doing well. Plugging along here on our next episode. We're talking about C-sections today. And I'm a title person, so I like to title our podcast. So we're going to call
like
this one, Oh, Baby.
I like that one. That's good. Before you said it, though, you should have had a pregnant pause. Never mind.
Oh, I see what you did there. I like it.
It's cheesy.
We could say I had a pregnant pause. Oh, baby, all about C-sections.
There you go.
So,
I like that.
Yeah, my history, and I think I talked a little bit about it, but before becoming a first assistant, I did work in labor and delivery for about 16 years.
That's right.
7 of those years, I was PRN. I went to work with a dermatologist.
Doing C-sections?
In those 7 years. No.
Oh,
No.
it's like it's a bit out of the scope of practice, isn't it?
No.
Oh, okay.
I did just to kind of get a change in schedule. It was when my girls were younger and I was raising them, and it just worked out better with my schedule. But I always stayed PRN in labor and delivery, and then ended up going back full time to labor and delivery. And then I went to first assist school from there. So C-sections are something that's near and dear to my heart.
Perfect.
I mean, I know I was able to learn so much in all those years working in labor and delivery. And so obviously this is the C-sections were the foundation of my surgical, practice and knowledge. So limited though it was, it's a really cool surgery to do. I still think it's a cool surgery to do. And you're taking care of 2 patients, right? We've got 2 patients and not just one that we're responsible for. So unique in that sense, of course.
Yeah. It's one of those surgeries that, like, when I'm on call for C-sections and I get called at 2 in the morning, I'm always really grumpy because I'm like, I got to go in. But then once that baby comes out, I'm like, oh, man, it's okay. Because you see that little kid.
I know.
And you're the first
And you're
person to greet
forever
him.
a part of that baby's
Yeah.
original birthday. I mean, it's great. Yeah.
You're like literally the first person to handle that baby. It's amazing. Yeah. It always turns me right around.
It is. And to think of the C-sections in the middle of the night, or even the unexpected C-sections, which, the mom doesn't want to be there. The mom doesn't want to be there. She's had a hard time. She doesn't want to be in the operating room delivering her baby like that in most instances. So,
yeah, that's
true.
It
kind of changes your tune when you get there and you see, okay, it wasn't too long ago, just a couple weeks ago, I got called at like 3:30 in the morning, like out of a dead sleep.
Yeah, it's always that way. Yeah.
It's like, oh, I really don't want to get up and do this, but when you get there and you see that sweet baby be delivered, it changes your whole outlook.
Yeah,
it does
sure
mine.
does.
It does mine, and I'm glad. I want it to. I don't ever want to lose that. It's always exciting, and exciting in a good way, and can be exciting in a scary way too. We're going to talk about some of that for sure.
Yeah, true. I always consider those cases for me in 2 phases. There's that frantic phase of getting them in, especially if it's urgent, getting them in, getting the spinal in, or God forbid, putting them to sleep, and then getting everything done. And then once the kid's out, you're like, oh, you could relax, take your time, take care of hemostasis, do what you need to do. The crisis basically is over, provided that the kid comes out okay and he's not, doesn't need to be coded.
But even then, you're passing the baby off then to the neonate team.
Yes.
And you've still got the patient in front of you to deal with. And there could be some things going on with the patient too that you need to pay attention to. And we're going to go into all that. But
that is true.
First, we're going to talk about the history of C-sections. And you're the historian expert out of the 2 of us.
I don't know too much about these. I mean, I know initially it was named after Caesar because he delivered via cesarean section. Is it Nero? Is that how it got the term cesarean section? I know the first.
Is that a misnomer?
Is it a misnomer?
I don't know. That's
the way I always understood it.
Is that an urban legend? Well,
urban legend? It might be a Roman legend. I don't know about an urban legend.
A Roman legend. Well, it wouldn't be urban, would it? I heard, because I always heard that too. I know exactly what you're talking about.
Well, then it turned out not to be true.
Then recently I read that it was just named that because the Latin word that it's derived from means to cut. I mean, it was like something really practical. So anyway, it was originated in the Roman culture Well, the Romans were originally the ones to do a lot of things, so I guess
Okay.
that's not any different than anything. But I had that. Oh, I want to remind people that we do have an episode on surgical history, the history of surgery in
That's
general, and I
we do.
do talk about the history of C-sections in that episode.
Mhm.
So if you're a geek like we are a little bit about, I can be a geek about it, but John's just the more knowledgeable one out of the two of us, and he
Oh, I'm so
retains that
geek about it.
information. I just appreciate, as I've gotten older, I appreciate learning about the history of that a lot more than when I was younger. But yeah, so I talked about C-sections. I felt like that was what I could contribute in that episode the most to. So I talked a little bit about it. But yeah, C-sections have been being done for centuries,
Okay.
centuries and centuries. And initially, I think as far back, I have about 1020 AD, but there's
Mhm.
evidence that it was even, they were done way before then. So
Oh, I'm
like
sure of
longer
it,
ago
yeah.
than we can imagine. Yeah. And of course, back then, C-sections were done primarily when the mother had died during childbirth and they were just trying to save the baby. So they just had to cut the
Yes.
baby out to try to
Yes.
get the baby, save the baby's life at that point. More importantly, the first C-section that was done where both the mother and the baby survived was at around 1500.
Right.
And that was in Switzerland by a Swiss surgeon. And he actually did that on his wife.
Oh,
The,
Jacob
the, mo-
Neufer, right? Yeah, that's the
yes,
doctor,
yes,
Jacob
that's
Neufer,
right.
yeah. I think it's pronounced Neufer. That
Yeah,
is
it's
correct.
Nufer. Yeah. So he, yeah, I mean, I can't imagine it, but mom and baby survived. So that's the first
Yeah.
recorded
1500
C-section where
means
they
before
both,
anesthesia too, which means she had to
right,
be held down.
right.
I can't even
I kind
imagine
of,
that, man. Because like, once they get in the abdomen and she screams, she's gonna eviscerate, right? I mean, things are
I
gonna come
know.
flying out,
Oh,
but
yeah. I imagine at
I
some
guess that's
point
the
you just
things
pass out
I
from
don't
the
yeah, oh,
pain.
yeah, I'm sure you would pass out from the
Mercifully,
pain.
yeah.
Yeah, but that doesn't last.
But anyway, fast forward, that's just a few short facts
Mhm.
about C-sections and how long they've been. The C-section is the most common surgery performed in the United States
Yeah,
today, still.
that's
It
true.
has been for some time. We do over 1 million C-sections in this country every year.
Wow.
One piece of information that I read said that
Mhm.
our C-section rate here in the U.S. is 32% of all births are C-sections. That
Okay.
seems
That's high.
very high. You had some stats from some other countries, some of them really low.
I do have some yeah, like Africa
Mm-hmm.
is only 3.5% for obvious
I
reasons, because
mean,
most
mm-hmm.
births are rural, they don't occur in hospitals or they use a midwife, but, um, yeah, in Africa is 3.5%, Asia's 15.9%, Europe is 19%, Latin America is 29.2%, and this one has North America at 24.3%, and
Right. So there's a
Australia
big
is at
difference in
21%.
that number that you read for North America. And
Mhm.
I mean, I guess, I don't know, and the number I read. So I don't know which one is more accurate, but we do know that we do well over 1 million of these every year in
Yep.
this country. And it is the most common
I did read
surgery. It is
that.
a major surgery for women.
Oh,
I mean, this is a
definitely.
major surgery, right?
Yeah.
It's not, it's not to be taken lightly. So I think a lot of women underestimate the the extent of this surgery. I
Yeah,
think we go
true.
through, I'm going to talk about those layers, but I think the most layers are entered and gone through in a C-section than any other surgery.
Yeah. Yeah. I mean,
We'll
typically
talk about it and you can tell me, I mean, that we can think about other surgeries and say, but there's 7 layers that are gone through. We're going to talk about that in a few minutes. It's interesting. Let's talk about some of the indications for a C-section. Why would a woman have a C-section? Need to have a C-section. The first one is obvious. We're going to talk about the repeat C-section. That's the
mhm,
scheduled C-section because she had a C-section previously. So that's
right.
going to be an elective situation.
I know that from the indications that I read, there's maternal indications and there's fetal indications, obviously.
Right.
And right,
And I
the
like to,
maternal indication,
yeah.
absolute maternal indication is previous C-section. That's the
Mm-hmm.
reason. And actually, it's more than two, I think was what I read, because you can do it. They do VBACs all the time
Yeah.
nowadays with the OR team on standby usually. So,
Mm-hmm.
um, but One of the other reasons I read was, like, obstructive lesions in the birth canal, like, if they had a big leiomyoma or if they had a malignancy even, or,
Mhm.
something blocking that birth canal or that would cause,
Mhm.
harm to either the fetus or the mom if the baby passed through that birth canal. So, if
Mhm.
they had previous
And
uterine surgery would be another reason
right.
because it could rupture
Yeah.
along that suture line.
Correct. With laboring. Yes, that's right. With those contractions, that uterus can rupture. And the same with the VBAC. And I do want to back up to that a minute and just tell people that a VBAC does stand for vaginal birth after cesarean section.
Mhm,
And that has become it has become, I think, more accepted, I think,
mhm,
because a lot of women, it's important to them. They want to give birth vaginally. And for whatever reason, their first baby's born by C section. With that second
mhm.
baby, they can deliver vaginally depending on their specific situation,
Yeah.
the size of but also the, even though it's unlikely, we're going to talk about the fact that if they had to have a vertical incision,
Mhm.
they're not a candidate. So that would,
Oh, they're not
like
a
a vertical
candidate? Okay.
incision, like if it was a sure enough stat C-section and for whatever reason they had to do a vertical incision on that
Mhm.
uterus, that would not be a candidate for a VBAC. But all those ins and outs aside, I wanted to let our listeners know what we meant when we said VBAC. It's vaginal birth after cesarean. And you're right.
Gotcha.
If they've had more than one C-section, that would eliminate that possibility as well.
Mhm.
So I've known, and it depends on the doctor. It depends on, they have to have an OR team readily available.
Mhm.
And I think they most of the time want a NICU. The hospital has to have a NICU, a level 2, I think, NICU available
Oh, okay.
for that situation. And some doctors just won't do them. Just won't. They won't do them. They don't believe it's the safest thing. So a patient would have to find a doctor that would be willing to labor her and go into that VBAC situation. So there's a lot of
Gotcha.
ins and outs to that, a
Mhm.
lot of discussion and controversy around that. But I have seen myself plenty of women do it. I've known personally women that have done it and
Mhm.
been successful. And so it is a thing and it's possible. So, but yeah, but you're right talking about the fibroids and uterine anomalies
Yep.
that would cause a woman to have a C-section is a
Yep.
thing
Another
also.
reason would be if they had, like, a prior perineal repair or if they had an anal anastomosis for, like, inflammatory bowel disease.
Mhm.
Anything where,
Mhm.
like, increased pressure and dilation down there is gonna potentially,
Yep.
have untoward consequences because the tissue's weaker there or whatever, so,
Mhm.
um, and then
Something else, John, that is less known, less maybe talked about,
eh,
is a history of herpes simplex. So
exactly.
if we have HSV and we happen to go into labor and there's an active lesion,
Active lesion, right.
we can't deliver vaginally. And so we have to do a C-section and that, do you know what will happen if the baby's born past a active herpes lesion? What can happen?
They'll get herpes, right?
It can cause blindness.
Oh,
That's what they
really? I did
worry
not
about. Yeah.
know that.
Yeah.
Okay, cause
Mhm.
blindness. I always knew that
Yeah.
if the mom had herpes and an active lesion, they would do a C-section, but I just never knew why, I never asked.
Yeah.
Oh, that's good.
I
So
hope
the
I'm not
risk of
making that up. Now,
blindness
all of a
that's why
sudden,
I'm
I
not
haven't talked
making
about
that
this
up.
in such a long time.
You
I'm
should
like,
have checked
I
it
hope
out
I'm not
before you
making that
mentioned
up.
it.
Okay, we just want our disclaimer is we are not educators. you, you're not receiving any educational credit for the
Yeah,
podcast.
true.
I hope I'm not lying, but anyway, I'm sure somebody will tell us in the comment if I just told a story. But it seems like that was the case. Yeah, that it affected their eyes. That was the concern. That was the biggest concern. So there were some instances where we had to tell the family of the patient, like if the
Mhm.
patient didn't want to disclose that I have an active herpes lesion,
Oh, okay.
maybe the family didn't know
Right.
the patient had herpes. And that's, a patient privacy thing. But this is also one of those things that family's present. The
Mhm.
family's there and involved in the birth of a baby.
Yeah, that's true.
So w- this is an industry secret. I'm gonna tell you. In that case, the baby's breech.
Oh, really?
and we're
That's what
doing a
they say?
C-section.
"Oops, baby's breached, gotta do a C-section." Okay.
So now anybody that's listening to this, if they know somebody,
Wow.
if
So if
somebody's baby was born,
they've had a breach,
you,
if they have had a C-section for a breach, that
yeah.
means they got herpes.
I
Okay.
mean, listen, you have to protect the patient's privacy, and it's really none of the family's business. But of course, they're going to be wondering, why are you doing a C-section? Usually that's known when the patient comes to the hospital for a labor check or whatever, that lesion is seen. Usually the patient knows they have
Mhm.
it, so they tell the doctor, but if they don't, anyway, just a little tidbit there. So we cannot deliver a baby vaginally through a past a active herpes lesion.
Oh,
So
okay.
that's a serious consequence of that, of having herpes. You might have to have it, and I actually did use that. Believe it or not, I did use that information with my teenage daughters
Okay.
as I'm working in labor and delivery in teaching them whether it was abstinence or safe sex practices. I actually
Oh,
used
okay.
that example for them and said, just to teach them that the
Uh-huh.
consequences of
Oh,
contracting an STD can go far, affect you far into the future. Just teaching your kids about consequences.
oh,
So
exactly. But that's when they change stuff too, because now it's STI, sexually transmitted infection, not
infection instead of
STD anymore. I'm
disease.
like, I like
It
STD. It
sounds
kind of rolls off
disease.
the tongue better. But no, I was
We've
just
said it
looking it up.
forever.
Kelly, you are correct. Herpes infection occurs in less than 1% of births, but it can cause severe illnesses in newborns such as blindness, deafness, seizures,
Okay.
serious
So,
infections such as
yeah.
viral meningitis. So yeah, it's
Yeah. So,
definitely, yeah.
yeah.
So you
So
are
a slew
correct.
of, yeah. Okay. Good.
You're not passing
Good
along
that I'm right. Not good
misinformation.
that yeah. But stands to reason that that a virus could cause serious implications
Mhm.
to a newborn who's immunocompromised and all
But I'm
that.
gonna
So,
remember that about breech C-sections now. Oh, she's got
it's
herpes.
like,
Okay.
really? Were
Stay
you
away from
really?
her. But,
Oh,
no, I'm just
yeah. Right.
but then I do
But yeah.
know.
So, no, it's because it's a major surgery that you
Yeah.
wouldn't otherwise have to have.
Yeah, it's major abdominal surgery. I mean, it takes a while to recover from, and then it comes with all the attendant risks of abdominal surgery,
Right.
adhesions, bowel obstructions later, possible
Correct.
hernias, all that stuff. So, yeah, although less
Yes.
chance with a fan and
Yes.
steel, but I do
Mhm.
know for the indications, there's fetal indications too for C-sections, which
Mhm.
we've just talked about.
Yep. Yep.
Breech is one of them,
Breach is one of them.
but non-vertex positions, I guess, is the catch-all term.
Non-vertex.
So whether
Have you ever
impacted
heard of
head, I
face?
guess.
Have you ever heard of face presentation? I mean, did you know that that was an actual thing? No, it's not a joke.
No,
I'm
I
not
know. I'm
joking.
just trying not
Yeah.
to. I was
No.
resisting the urge
No,
to make an off-color
there's
comment,
actually no,
but
no, John, refrain. Family friendly show.
exactly, that's anything.
No, it's actually really scary. A face presentation can be
Mm.
detrimental to the baby. If you can imagine
Oh yeah,
somehow a baby's head getting craned back coming down through the birth canal and their face fronting, right? That's
yeah, yeah.
bad, 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 bad. So I've actually seen it where a doctor was checking a patient, checking the cervix for dilatation and
The kid was looking
felt
back at him.
the felt facial features, and they have to actually manually push the
To
child
back
back
up.
up out of the
Yeah.
birth canal, and we take them back for a stat C-section. So that can happen as well. But the point here for our podcast is that non-vertex presenting would be, whether it's buttocks breech, frank
Hmm.
breech is when the feet are coming out first.
That's got to be
Um,
odd when you
yeah.
go when you put the speculum in to look and see the cervix and you see an eyeball looking back at you. I guess that would be
Oh no, that
that would be
would
kind of
be
weird.
that obvious. It's more of a feel thing, I think. But
Yep.
anyway, could be detrimental to the life of the baby. But you're right. So
So another
transverse lie is
what would be
another one where the
another
baby's
fetal
laying
what
crosswise.
would be another fetal indication for
Well,
C-section?
fetal distress. I mean, if that
True.
baby is showing any signs of distress in the heart rate,
Mhm.
and there are ways you look at that fetal strip and see if their heart rate is decelerating,
Mhm.
especially after the onset of a contraction,
Definitely.
is especially indicative of fetal distress, called late decelerations. And when the baby's heart rate goes down after the onset of the contraction and stays down, that's indicative of fetal distress. Tachycardia is indicative when
Mm.
a baby is tachycardic can be indicative of fetal stress,
How
and that
about
can
more than
cause
one baby?
more than one baby. Yeah, multiple
Twins,
births. Not
triplets?
necessarily do they have to be delivered by C-section, but most of the time
No,
that's
but it's
kind of
an indication for
anticipated.
C-section, yeah.
And it is an indication for sure.
And I did my first set of twins a couple of weeks ago. I've been doing this a
Yeah.
long time, and I've been doing C-sections a long time, but, it's just the law of large numbers. I've up until recently, I've never done a crash C-section, and I've never done twins, but 2 weeks
Mhm.
ago, 3 weeks ago, I did the twins, baby A and baby B. I didn't know they labeled them A and B. I didn't know that. At least they do at
Mhm.
this
Oh,
hospital.
yeah.
And then
Yeah, that's
one of
how
the
it's
girls
done, yeah.
there, the guru of the GYN up there, Jenny, she's fantastic. I love her. She told me a little trick. She goes, for baby A, when you clamp the cord, use a Kelly, and
Mhm.
on the baby, use a plastic umbilical clip. And then
Mhm.
baby B, use a Kelly and then 2 umbilical clips on the other one. I mean,
Mhm.
it sounds obvious at the time, but I never would have thought of that on my own,
Right.
because I
Yeah.
mean, if they're twins, they look alike, you're gonna mess them up. Although these were
Right.
fraternal twins, they were just the cutest, man. It was
But still
amazing. They
just
were
to keep them
gorgeous. But
apart
right, yeah, to keep
right
them
there,
apart,
yeah.
yeah.
When you
And,
can look at their cord and how they're clamped, yeah.
yep, it was cool. But yeah, so that's one reason. Abnormal, what was the other reason you said it? Oh, some congenital abnormalities too. So,
Mhm.
I would think
Mhm.
like, I don't know. I would even think
Hydrocephalus
it was a
or
yeah, so oh, yeah, exactly. Or
would be
maybe
one good example.
gastroschisis or something like that, where you
Right.
don't want the
Of
baby
course.
squeezing out through the birth
Mm-mm.
canal.
Right.
Um, and like you said, fetal compromise and then HOIPs, like you
Right.
mentioned.
A
I mean,
a,
breech, Ooh,
yeah. A common maternal indication also is
mm.
PIH, pregnancy-induced hypertension,
Oh,
with
right.
which is AKA
Yeah, I was
preeclampsia.
gonna say, isn't that
Preeclampsia is a
called
common
preeclampsia?
term for PIH, which can then turn into HELP syndrome. HELP syndrome just stands for it's a result of them having hypertension with their pregnancy,
Oh,
but
okay.
HELLP syndrome stands for hemolysis, elevated liver enzymes, and low platelet count. So it can send a mom. It can bad cases can send the mom into DIC.
Oh,
So
not good.
uh, that can be that's a serious morbidity
Wasn't the first
of
episode of ER, didn't he do a C-section, where the mom died and he did like an emergency C-section to get the baby out, if I remember
oh
correctly?
could have
I
been
don't
because
remember.
I will tell you that in that PIH or HELP syndrome, the cure
Mhm.
for that is to deliver the baby.
Oh, really? That's it?
So you deliver the baby and they do continue, but they want to intercept that before it gets to HELP syndrome, right? I
I
mean, they don't want it
see.
to progress and they don't want those liver enzymes changing and all that. So,
Hmm,
um,
interesting.
yeah, so that's the cure for it, just to get the baby delivered. Yeah, and they'll treat the mom with magnesium sulfate and other medicines to, keep that blood pressure down, but typically
Hmm,
they recover and it resolves once the baby's delivered. So that's a very common indication for C-sections. And that would be typically classified as an urgent, not a stat, but like an urgent C-section. And you're going to talk
okay.
about the different grades of the urgency grades. He's got the
Exactly.
technical terms. I just talk about stat, urgent, and
Yeah, that's fine.
call,
I didn't
and
know about the
elective, but
grades until I
I
started
didn't even
reading
talk
about
well, I
this.
know, but that's interesting. We're gonna use technical terms on here. We're gonna be professionals here.
But, like, I've
Um,
never had a doctor say to me, "Hey, hurry up, I got a grade 1
we're gonna
C-section."
grade
I'm like,
that's
wha
true.
huh, what?" You know? But a grade
True.
1 emergency C-section, immediate threat to either the mom, baby, or baby's life, or both,
Right.
I
So
guess.
that's gonna be a
So,
stat. I
stat
call
or
that a stat
crash.
C-section, and that means you're going immediately. You're getting back there as
Mhm.
quickly as you can to deliver that baby.
Yep. And, like I said, only until recently, thank God, because those are not fun cases. I did a crash C-section, and that doctor started without me, and she had that baby out in 30 seconds.
Mhm.
'Cause I was doing a
Yeah.
C-section in the other room, and we can see in, and we were closing, and the doctor said to me, "Forget this, go help her. I'll
And
close
that,
this." And I
I
was
would
over
call that a
there.
grade 0.2 because that
Yeah,
we need to have one right before stat because there is one. A crash C-section is when
crash,
I'm
yeah.
telling you you don't count,
Nope.
you don't do
We
anything,
didn't
you
even
get a
tie our
knife
gowns up,
and
we're
you
hanging down over our
you
shoulders because we just had enough time
no.
to put a gown and gloves on, and that's it.
Yep.
I mean,
And y'all, there it happens.
right,
It is that fast. You have got to move that
my
fast to get
hat's
that
off
baby
to
out.
that doctor, though. I mean, she had that
Uh-huh.
kid out in 30 seconds. The kid did great
Yeah.
later. The kid did great later. I mean, he wasn't doing well. They life flighted him out to, a bigger hospital.
Uh-huh.
But I'll tell you what, I was doing the one C-section with the other surgeon, and she said when she came in the room, she said, "Hey, I walked by room 1, and I heard the monitor desal, so why don't you have Doctor So and so go check on that?" And the next thing we know, they come busting in the doors through the other room,
Yeah.
but the fact that she caught that just by walking by, heard it,
Yeah.
had somebody else
They
check it
it
out. The baby had a prolapsed cord
uh-huh.
sticking out
Uh-huh.
of the
Of the
cervix
vagina.
with the
Uh-huh.
nurse
Through
coming
yeah.
in, pushing up through
Yep.
on the va you know, through the
And
vagina
those
up, and also had a nuchal cord as well.
yeah, and I'm glad you brought that up because that is I would say that's one of the most common scenarios for that kind of C-section. And I've done my fair share of those, and they are very scary,
Okay.
and you've got to if you can imagine if everybody can imagine that, if this is the cervix and that cord is prolapsing down through it, well, what's that doing? That's cinching off all of that blood flow. I mean, you're
Mhm.
literally cutting the baby's life flow off. I mean, you're cutting off their oxygen, kinking up that hose that's literally giving them what they need to live. So it's a matter of second. I mean, it really is a matter of minutes, or not even really minutes. I mean, you got to be able to get it out fast. And so,
Yep,
yeah, I've
true.
done them, been there and done it. And all you need is a knife. All
That's
you
it.
really need is a
The
knife.
knife, that's it.
It'd be nice if you had some laps to get the blood out of the way, but
Yeah,
all
you're
you
not
really
even
need is a
worried about
knife.
that. Like, yeah, I've never
Mhm.
yeah, I mean, that was amazing, so yep, so then a grade 2 is just an urgent C-section, so that could be like, intermittent desals or, you know,
Right, or that
anything
patient
that
with
where the baby needs to
PIH and
be
her
delivered
labs aren't
now,
looking great. Yeah,
Right,
just
yeah.
like we need to do it. We need to move toward that and do it,
I would
but it's
say
not
failure to
like a
progress would
stat.
be another one,
It
prolonged
it is.
labor, that kinda
Uh-huh.
thing, so
Yeah,
and
arrest of
then
dilatation. Sometimes that cervix just stops dilating
yep.
and the labor is prolonged. Maybe their membranes are ruptured. We don't want
Mm,
their membranes ruptured. 24 hours, you're getting, they need antibiotics because your
yeah.
risk of infection then is going up. If
Oh, that's true,
the
yeah.
membranes have been ruptured over 24 hours, then you're looking at increased risk of infection. So you're going to be looking at, okay, what are we doing here? Or what are we doing to speed along this labor, or
Mm,
either talk about doing a C-section? Shoot, they would fall in that category. Yeah.
okay. So, yeah, there's 4
Hmm.
grades. The grade 1, which is the emergency C-section, immediate threat to life of mom or baby. Grade 2, which is urgent, I guess you'd call it, C-section for,
Hmm.
um, whatever reason. Grade 3 is
Hmm.
just non-scheduled. That's what it had listed as, and grade 4 is a scheduled. So,
Okay.
I
Right.
don't really know
Yeah.
how this fits in. I've never heard anybody classify it like that, but I've
Hmm.
never been told, like, when I got a report, "Oh, it's a grade 2 C-section," or, I've never ever
Hmm.
heard that, nor have I read it in any post-op reports or HMP or
Right.
anything, so, um,
Right.
but that's
All
some of the
right.
indications, then we
So,
have the
yeah.
technique, right? So,
Yep.
there's
Surgical approach.
typically
So,
3 types
yeah.
of incisions used for that surgery. So, 1 is a
Hmm.
fan and steel, 2 is the Joel Cohen incision, which is 2 centimeters above a fan and steel, and straight, whereas a fan and steel kinda curves up and the edges,
Hmm.
it's 2 to 3 finger breadths above the pubic symphysis. The Joel
Hmm.
Cohen is 2 centimeters above the fan and steel incision, and then there's vertical or midline, which they don't do anymore pretty much. So,
Hmm.
but in the older back in history, in antiquity, they used to do that. That was a midline incision for C-section.
Right. 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 And so obviously the patient is typically supine for this.
Correct.
There's always a Foley. There should always be a Foley. We want that bladder down out of the way.
Mhm.
Um, the anesthesia of choice is usually an epidural,
Yep, or spinal. We do a
spinal,
lot of spinals where I am now.
or, well, they're going to only have an epidural if they've been laboring,
Right.
John. So the
True.
epidural, and not always does an epidural work
Right.
sufficiently. So sometimes they'll have to additionally pull the epidural and put a spinal in, anyways. But I have seen epidurals work just fine, carry them through a C-section. So
Mhm.
epidural spinal is very common, the most common, actually. And general
As a
anesthesia
last
only
resort.
takes place, it's a
Yeah.
last resort. It is a last resort. And that would be like in that C-section that did where the doctor had to the stat that you were just the crash C-section you were just talking about, like that patient.
That girl, though, they did her with an epidural. She
Oh, she
was a
had an
trooper,
epidural, and
man. I
she
mean,
was
that girl,
okay. Okay, so she already
they
had an
bolused her
epidural,
epidural,
okay.
but I was surprised. She remained calm. It
So
was
that's less common
kudos
for
to
an epidural to
mom.
be working that well. Good
Yeah.
for her that it did.
Yep.
Excellent. Kudos to the CRNA or anesthesiologist that put that in.
Mhm.
But in that situation, most of the time, if they have an epidural placed, it's not working. It's
Yeah.
not going to work. So they'll just slam them to sleep. Now, if they're going under general anesthesia, the the OB team, the OB doc is standing there with a knife in their hand,
Oh, right, yeah.
poised over the skin, and as soon as that anesthesiologist says go, you
Yep,
go. You
you
start
go,
going, and you get
exactly.
out as quick as possible because that general anesthesia is gonna affect the baby. So all kinds of factors here, all kinds of things going on,
Mhm.
not to mention what condition is the baby gonna be in when the baby comes out. So we've got that neonate team ready to go, ready to receive the baby, whether it's, RT at your hospital that receives the baby,
Mhm.
whether it's a NICU team, a labor and delivery team, can
Pediatrician.
yeah, pediatrician, neonatologist could be in there, depending on the situation, depending on your facility.
Mhm.
RT actually receives our babies at our hospital.
Okay.
We do not have a NICU at the hospital I work at.
Yeah, they don't have one where I
It's a
am in
smaller
now.
labor and delivery. They're not hugely busy. There's no NICU. So RT comes up and manages the babies when they're born. So, yeah, lots going on. So, anesthesia we talked about. Um, the incision is right there, the bikini line. So, fan and still, if they can't because of how the uterus is lying, or if the baby's sitting higher, you might see a lot of doctors feel around and kind of feel where the baby's head is, feel
Mhm.
how that uterus is lying. Sometimes they will go higher. I never knew the official name for that incision. I just knew that sometimes depending on how that uterus felt, that we would go a little bit higher than the typical fan and still. So,
You mean in, like,
um,
I the hysterotomy, or you mean the actual skin incision?
no, the skin. I'm talking about the
Oh, okay.
skin. Yeah.
Okay.
So, yeah, where they place it, the name you just gave it, I
Oh,
don't know
gotcha, yeah,
somebody's.
yeah,
I
the
guess it was
Joel
somebody's
Cohen.
name.
I didn't know that
Yeah,
until recently either, but, yeah, I just knew
yeah.
there were 2 different, yeah. But, yeah, they use the belly of the knife blade to carry the incision all the way down to the fascia, and they do it in
Mm-hmm.
as few swipes as possible, and usually, most
Right.
places, they don't mess with the bovie on the subcutaneous bleeders. If there's one that's really big and brisk, I'll get it with a hemostat, and they'll bovie it, or the doctor will
Mm-hmm.
get it with a hemostat, and I'll bovie it.
And again, that depends on your surgeon and who you're operating with. A lot of them really, especially in a more controlled situation,
Yes,
you want to try to maintain that hemostasis in that sub Q. I
exactly,
mean,
and if it's a
if you're in a
first-time
stat
C-section, a
situation, you
lot of
don't.
times
Just
we'll use
depends.
blunt dissection to get through that sub-Q tissue, and
Hmm.
then just usually the docs I work with make an incision on either side of the fascia, either side of the rectus
Hmm.
midline, one, on my side, one on her side, and then we develop that fascial, incision with a pair of scissors and pickups. So,
Hmm.
depending on where you are and what their level of comfort is with you, sometimes the doctors will make the fascial incision themselves. Sometimes they'll just do half of it and let you do your half.
Right.
So yeah,
That's
so
more common for the assistant to do. I
yeah,
mean, I've had surgeons just automatically do both sides, but it's more common for the assistant to do the half away, going away from. So in other
yes,
words, the surgeon would do the half the fascia that's toward me, and I would do the
right,
half toward them. One thing I do want to mention
exactly.
about positioning for this is the pannus. So in a very heavy patient,
Hmm.
we would need to tape that belly back. So I like
True.
the track C retractor. Have you ever seen a
Yes,
track C retractor?
that's
So
that
those are
clear drape
great.
that
A
you stick on
panicculus. It's a
it. Yeah,
panicculus. Yes,
it's
it's a
great. I love
panicculus
that thing.
retractor, and I'm telling you, that makes all the difference. But y'all, when you have an obese pregnant woman, you have got to get that pannus up to get to the area, to get to that fan and still area. I mean,
Yep.
you've got to get that flap up. So if you don't have a Traxie, and we don't have Traxie retractors at my hospital, unfortunately, you just have to use the tape. You have to use your tricks with the tape and benzoin on their skin to try to, you put that tape on the upper abdomen and kind of pull back over their shoulder and tape it to the bed. Something to be aware of when you're positioning the patient. If you don't know that, you want you want to get that belly back as much as you can to give us exposure to getting into that area. So, but yeah, continuing on with our layers, and we're going to talk about the 7 layers that we're going to go through for a C-section. So a C-section, we cut through more layers than any other surgery. So those 7 layers in a C-section are going
Mhm.
to be skin, sub-Q, fascia, muscle, peritoneum, bladder flap, and uterus. So that makes up 7 layers. And if you're, especially if you're CST, for the CST side of this, you want to know that because you want to know all of those layers don't have to be closed. So it's nice to know your suture that you need for each layer that we're closing. That's why that's important from that
Yeah, true.
perspective. And as the first assistant, you can help your CST know that, and you can make sure you've got the right sutures when you know what the surgeon wants on the, peritoneum versus the fascia. Do they close the muscle? Do they close the bladder flap? Those are both kind of optional and
Mhm.
don't have to be closed. But what they use on the fascia, what they use on the uterus, of course, to close. So knowing those specific sutures, usually surgeons have, like everything else, they have a routine, they have their sutures they want for those layers. So
Mhm.
that's why that's one reason why that's important. And another reason, obviously when we're looking at the bladder flap, you want to make sure that you're not getting into the bladder. We want to keep the bladder intact. So you want to be familiar with what that looks like and
Mhm.
keep that out of the way with that bladder blade. Let's see here. What else do we want to talk about? So we're cutting down. So we just were talking about cutting through the fascia.
Mhm.
We get the fascia, and then once you've incised the fascia, then you're going to grasp the upper portion with the cokers. She's going to peel that fascia. They're going to
Mhm.
peel that fascia away from the muscle layer. You want to
One
then go
caveat I
to
wanna
the
add to that, so if you're the assistant, obviously, and it's the surgeon is relying on you to make your fascial incision or continue the fascial incision on, for your side. If you've never done it before, be sure to tell that to the surgeon. I mean, ask them to
absolutely.
teach you the correct way if you're uncomfortable doing it. Don't just say, "Okay," and do it because you've seen it done before, because believe me, all kinds of bad things can happen. But typically what I do is I pick up the fascia, the inferior leaf of the fascia with the pickups, and then I'll take the scissors and I'll bluntly dissect under the fascia first and spread them. So I'm
Yes,
like
that's right.
relieving the muscle, separating it from the muscle and the underlying tissue, and then extend it out laterally. But then as I get lateral, I will curve it
Curve up.
cephalad towards the head to avoid the
Right.
epigastric vessels. So that's
Correct.
key to curve it up as you're going away. And then, yeah, perfect. Like you said, 2 cokers superiorly, use blunt
Yeah, we're
dissection
gonna
to
peel that
separate the
fascia.
muscle. Yep.
Yep. Yep. And then do the same below. You
Hmm.
grasp the inferior fascial edge and lift up, and we're peeling it off the inferior muscles down below. And
Typically, you have to
after,
use scissors for that, though, to get the pyramidalis muscle down. You
yeah, and
know,
that's typically the surgeons doing that. I'm lifting up. You just want to lift high on those
yes.
cokers, kind of pull that fascia
I
way
usually
up
lift high
for
and
'em.
provide counter traction on the muscle, push down while they're
Correct.
doing theirs. And I try to do my side. I use the sponge as much as I can with my blunt dissection because
Yes.
that'll give me
Uh huh.
grip. But
Yep.
eventually, invariably you'll get a bleeder. So I usually just bovie it. If
Yeah.
it's really
Right.
brisk, if it's not brisk, I'll just leave it alone.
Right.
And then
So
once,
after that, we get through
yep,
the fascia. We,
split the
just
muscle.
bluntly split the muscle,
Hmm.
obviously. The muscles are going to split right apart. They're already stretched for us with the pregnancy.
True.
So you can see that really easily when you get in there, split that. And then we're going to incise that peritoneum, and which is a really thin layer.
Hmm.
It's stretched
Yep.
thinner than normal, even because of the pregnancy. Sometimes they'll get a hemostat and just kind of take a tiny bite and hold it up to put tension on it so they can get in there with
Hmm.
a scissor, a Metzenbaum's usually a Metzenbaum scissor. So once we're in the peritoneum and then we've got a little hole, then we both stretch, right?
Hmm.
Once you can get your finger in and it just kind of opens up, and then you can kind of get your whole hand, like the width of your hand in.
Yep.
And it's brutal. It sounds brutal and it feels brutal to do it, but you're kind of pulling
Hmm.
against each other to kind of get that open. And then you can place the bladder blade. You can get that
Hmm.
bladder blade down there, and that's when she's gonna. I keep saying she because I work with female
Most of them are
obstetricians.
females.
So
Yeah.
yeah,
I work, yep, a lot
they're
of
gonna
them.
get that bladder flap down. So they're gonna
Hmm.
see that plane where the bladder kind of joins, that flap of tissue from the bladder is on the uterus there. And so again,
Mhm.
Mets and bombs and Russians typically, and they'll create that bladder flap. And then you can get that bladder blade retractor
Mhm.
really down in there and kind of retract that bladder
Yep.
away from where you're going to be cutting that
If I
lower
need to, I
uterine
usually
segment.
sweep it down with a sponge stick and then put the
Yes.
Doyen retractor in or the bladder blade in. And then I
Mm-hmm.
usually have a Richardson that I'm holding, posteriorly
Correct.
or
Yes. Up front,
superiorly.
up top. Yeah.
Yeah. And
When
then
they're making, yeah, they're going to get the knife and they're going to make that uterine incision. At this
Mhm.
part, when she's making the incision with the knife, I usually have the CST pressed down on that bladder blade to keep that in place so I can
Yes.
suction the line, the suture line on that because it's going to bleed. She needs to see how
C,
thick that
right.
uterine wall is.
Exactly.
We don't want to injure the baby's head. So I'm sucking the line and pulling up on that Richardson up
Mhm.
top, like you just said, and keeping that out of the way. And then when they feel like they're thin enough, if sometimes they can get that uterine wall thin enough that then they can just pop a hemostat. They'll ask for a hemostat, pop a hemostat in there and spread it and finish getting that uterus open that
Mhm.
way.
Or use their blunt
Or use their
dissection.
finger.
That's
That's
ideal.
true.
Do you find
Mhm.
that they make a curvilinear incision, like a little smiley face in the lower uterine
Uh-huh.
segment, or do they make it
Yes.
just a regular straight across?
Yeah, they curve it because what do we not want to get down into laterally over there? We do not want to get into that uterine artery.
Right.
So they're trying not to go too far lateral there. So curving it up does protect that. Yeah. Yeah, that uterine artery, we're trying to stay out of that. I was trying to think if there's anything else
Mhm.
we're trying to avoid with that.
And then at
But
that
yeah,
point,
so
they
then you
usually,
start delivering. At
yeah.
that point, you got to start getting that baby's head out. Now, some complications that can come to play are if the baby's head is wedged down in that birth canal.
Mhm.
If that patient was pushing, actually in the pushing phase for any amount of time, and that
Mhm.
baby just wasn't descending enough to be born vaginally, you've got to reckon with a head down in there. So you don't know what you've got to be, as the first assistant, you've got to be ready. It's a very smart, unless you're very tall, smart to have a step stool on your side to get some height because you're going to have to give fundal pressure to
Mhm.
push that baby out well, you're going to have to push, like find the baby's butt. Typically, if it's a vertex baby, you're finding their hiney to push on up there and
Mhm.
help push the baby out, which is what the body would be doing in a vaginal delivery. What are some tools
Typically,
we can use if they can't get the head out?
they use the
The head can't be
kiwi or the
delivered.
delivery forceps. I've seen the kiwi
Correct.
used
So
more, but ideally,
kiwis,
yeah, they just want
very
to.
common.
Yep.
Yeah, that suction. So if you don't
Yeah.
know, the kiwi is the self-contained suction cup, and it's like
Mhm.
got a little cap on it. You put it to the maybe we can get some pictures, John, and show when we're talking about this.
Mhm.
But you place it on the baby's head. That seal's got to be good on the baby's head. So at this point,
They put it on the
typically
crown of the head, right?
the
No,
part of the
yeah,
part of the baby's
not on the
head
fontanelle.
that we're seeing is like back here. Yeah. Um, it helps with the baby's head. So if you can't get a seal on that kiwi, it's smart to get a dry lap and dry
Mhm.
the head that you can see, and it'll seal better. And then you've
Mhm.
got the pump up, so then you apply the suction, and that kind
Mhm.
of just helps. They can help, gives them some pressure that way.
Typically, a physician
Simpson
that does that,
forceps,
in my experience. I've
correct.
never
Yeah, that's
run the
right.
I've
That's
never run the
right.
kiwi, but you may be in an institution
I have
where they
pumped it
do
up.
that.
You can pump it up.
Oh,
If sometimes they have to use both hands to kind of hold it on there or
mhm.
position it. It just depends on the circumstance. You can pump it up for them and then they pull. I don't pull,
Mhm.
but I have pumped up the suction on it for them if they're trying to hold it on there with both hands.
Okay.
So you can pump it up and apply the suction, but no, you should never pull. As a first assistant, you should never be the one pulling the baby out
Oh,
with the
yeah, no,
kiwi.
no, no, no,
Yeah,
but,
so
what I will do, though, is I
um
will as they get closer, I don't push on the mom's belly until the surgeon tells me to, so I don't provide
oh
fundal
right,
pressure
you're
until the
standing
surgeon
ready.
tells me to,
Yeah.
but
Mhm.
I will tell the surgeon, "Hey, I'm ready to deliver fundal pressure when you tell me."
Correct. That's exactly
And they
right.
usually say, "Okay." And then at that point, I'll usually look over the drape or not, and I'll just say, "Hey, mom, you're gonna feel me push on your belly really hard here,"
Right.
just so they know to expect that.
Good point because they say it feels like an elephant sitting on their chest when we
Yeah.
do that. So I
And
do the same thing,
some
John. I
people are
warn them that
very
it's
nervous,
coming.
especially if this is happening as an
Absolutely.
emergency, and
Mhm.
anything out of the ordinary is gonna set them off, so I just try to tell them as much as I'm doing as much as I can, and especially stuff like that, so
Right.
I'll tell her,
Right.
"Okay, you're
That's
gonna feel me
important. I'm
push on
glad
your
you brought
belly
that up.
now."
Yeah.
When she says, "Okay, give me
Because
fundal pressure," or he,
because that patient's awake most of the time. They know what's going on. Their partner or coach is in there with
Yep.
them, and yeah. So that's a very good point that you're first of all, you're remaining calm. You're always aware of what
Oh,
you're
yeah.
saying, how you're communicating with the doctor because they are right there. They can hear everything.
Mhm.
And we don't
Yep.
wanna alarm them for what's going on, so staying calm is huge, and I'm glad you mentioned that too. Yeah, I call it assuming the position. The surgeon can
Mm.
see that I'm stepping up on the stool, I'm feeling around on their fundus to kinda see where
Right.
my best pressure point's gonna
Exactly.
be, and then I say, "I'm ready when you tell me I'm ready." And that's right, the communication there is important. So hopefully we can get that head delivered. Once the head is
Mhm.
delivered, we're feeling a lot better about things. Can we have a shoulder dystocia in a C-section? It's not as common as in a vaginal delivery. No. Once you get the head out,
Mhm.
typically we're good. That the rest of the body's going to come out. A lot of times, the first thing they want to do when that head is delivered is
Mhm.
suction, depending on the scenario. Sometimes we just want to go ahead and get the baby delivered and get them out of there, and start assessing them and cleaning them up and getting their mouth and nose suctioned out.
Yep. First thing I
Um,
do when the head is delivered, and that's obviously bring the head out, and then they'll reach under and grab the shoulders and the armpits and lift the baby out if they can.
mhm,
I look and see where the cord is to see if it's wrapped
mhm,
around the neck once or
mhm,
twice or 3 times.
mhm.
So, and then I usually call that out because the neonatologist needs to know it and
Needs to
whoever's
know, right?
scribing
And
needs to
sometimes the
know.
doctor's not paying attention
Right, so I'll
yet, so
just
you
say
can
nuchal
say
cord or nuchal
nuchal
cord
cord,
wrapped
or you want to
twice.
announce
Yeah.
right, or you want to announce meconium.
Right,
I didn't
exactly, that's the
mention
other
that
thing,
when we
yep.
get into that. When she breaks the bag of water right after that uterine incision, if you see meconium, that's an important thing to yell out and let them know we have meconium stained fluid. They need to
Yep.
know that. So,
The tech pretty good, and they, are usually call that out before I get the chance, but if I
uh
see a
huh,
nuchal cord or a knot in the cord, I've seen a true knot in the cord, like, literally, like, you tied a knot
yes,
in the cord, it
uh
can
huh,
happen,
uh huh.
and, yeah, so
Yeah.
I
So all
usually
those are
say that.
variables that we need
Mhm,
to be aware of and say. And usually they can see the field. I mean, we want to try to stimulate. If the baby comes out pink, crying, tone is wonderful,
mhm,
reflexes, those reflexes are there and they're, crying and we don't have anything to worry about. But if they're a little floppy, their tone isn't
mhm,
there, we're going to talk about APGARs and what we're looking at. We'll go ahead and talk about, so the APGAR score is that score that we're judging them on, assessing them at 1 minute and 5 minutes
mhm.
to get that APGAR. It's just a general score to tell us about the well-being of the infant, of the baby that we've just delivered. So the APGAR is based on color, skin color,
Mhm.
tone, muscle tone, reflexes, heart rate, and respiratory rate. Obviously, we don't have a stethoscope on the field,
Mhm.
so we're not assessing their heart rate. There are certain things you can tell if their heart rate's fine. If they come out floppy and,
It's
not
typically,
breathing and
though,
blue, we
I don't
know.
at your shop, how do they do it? But where I am is typically the team that receives the baby is what gives the APGAR score.
Right, we keep them on the field for 1 minute.
Mhm.
They assign the APGAR score, yes, you're right, but we want to be thinking of these things as the
Oh,
first
sure.
assistant
Mhm.
because we've got the baby on the field for the first minute. The standard now is to leave the baby attached, for a full minute
Right, before you
before
clamp the
cutting the
cord.
cord. That
Yep.
that was not the case before. We always
Yeah, clamped immediately. Yep.
back in my day, we clamped and cut immediately, but now
Yep.
they've changed that standard, and so we keep that baby hooked up for a full minute, and they do start that timer when the baby's born, and they let us know when a full minute has gone by. And I try to exsanguinate the cord a little bit
Mhm.
before I clamp and cut. I'm usually the one to clamp and cut the cord.
It's a
But
good
yeah, I'm
That's a good
looking. So,
caveat that you just gave too, by the way, about exsanguinating the cord
hmm
before you cut
yeah,
it, because
yeah,
that
you can make
wasn't
a mess.
something that, was in my purview until just recently. It wasn't something that the doctors allowed me to do. So I didn't know, I just double clamped it and cut it, and yeah, you can cover everybody at the surgical field with blood when you cut,
Right. And
a,
well, you're just giving that baby
an
too. You're
umbilical
kind of giving
cord.
them that
Yeah.
last little bit of blood that you can.
Yeah.
I mean, it's just really a simple move, but you're just kind of milking down that cord towards the baby. You're giving them that last little bit of blood flow, and then
Yep.
as soon as you cut the clamp and cut the cord, what happens in that newborn is a miracle. I mean,
Oh,
I
yeah.
mean, actually not, but as soon as they come out and take their first breath, really is a miracle, and how
Mhm.
their little cardiovascular system has to completely rework
Switch over, yeah.
itself. It's just amazing. But
But how do they do
yeah,
it
so you
how do they do it where you are? Because I know at previous places I've been, a lot of it has to do with OR setup and where the incubator is as opposed to who hands the baby to the
Mhm.
receiving
Right.
team. Typically, at the last place I was at before here, the assistant side was right in front of the incubator, so the assistant was always
Mhm.
the one to take the baby and give it
That's the
to
way,
the
yeah.
neonatologist or pediatrician or whoever's receiving the infant at that point. How do they do it where you are? Does the surgeon
Yeah, I
do
mean, it's
it?
the same. Well, I mean, this no, the surgeon would have to walk around the first of all, our C-section room is so tiny, it's awful, and we have
Most
to
of
go all
them
the way
are,
up to
yeah.
labor and delivery, we don't do them in the OR, so, the incubator just happens to be on the side that I stand on, so I'm the one
Oh,
that
okay.
passes the baby off, yeah.
I did work with one surgeon, though, that wanted to hand the baby off herself, so she
Mhm.
actually stood on the assistant's side and did the case from there, even though she was right-handed, which I thought was odd, but
Oh,
that was
yeah.
just the way she did it, but
Wow, that would be tricky, I'm trying to figure out how you would do that if you're
yeah.
right-handed. Hmm,
But
okay.
she was,
Well,
she was
you know.
didn't rely on us for much, unfortunately, but,
Mhm.
that's a great I just love that feeling of handing that baby off,
Yeah,
I love it.
yeah. But my point of knowing what the APGAR is, what it's judged
Mhm.
on, is you can kind of give now, they're well able to see, but sometimes they can't feel the baby's tone. They can see the color. I just like to announce to them, baby's a little floppy, mainly it's with the tone that you're kind of giving them a heads up.
Oh, do you?
And if they look a little blue, if their color's off, I might tell them the color's off a little bit, Um, just kinda knowing that's just my training that's there. I was NRP certified, neonatal resuscitation, certified
Oh, okay.
while I was in labor and delivery. So I could it's like CPR for a neonate is what it is up until I obviously couldn't give medicines just like I can't in a real code now,
Mhm.
but trained to assess and up through chest compressions. So
Oh, okay.
on neonates. So that's just, my little thing that I'm going through my head and I'm kind of grading the baby as I'm drying them off on the field and looking at them. So just knowing some
Okay.
ways to stimulate them if they aren't really crying, if they're kind of floppy, you can really briskly rub their back and kind of get them stimulated. You can flick the bottom of their feet and kind of get them because you want them to cry, right? We want them to cry and we want them to work that fluid out and all that. So just some little tips and tricks there. Nothing big. You've got a team in there, like John said, you're going to pass the baby off to the neonate team and they're going to take care of any treatments that the baby needs. But then, yeah, once that baby's off the field, we're going to deliver the placenta. The entire placenta needs to be delivered. We don't want to leave any fragments behind. That's a bring back. If any retained placenta is in the uterus, that's going to be a bring back to the operating room more than likely
Mhm.
for
Now, do they
bleeding.
have you remove the placenta, or does the surgeon do it? Or
The surgeon does it. Yeah, typically the surgeon does it. Hopefully, it's delivering by itself, and there doesn't have to be a lot of manual
Mhm.
delivery of that. But if not, no, the surgeon does it. No, I can help once the placenta is delivered, and you'll see the last membrane will still be attached to that
Mhm.
wall. You can help. You can get a ring forcep and kind of help ease that out. You can be ready with a dry lap
Mhm.
to hand to the surgeon to help clean it out. But just kind of eyeballing it with the surgeon and making sure it looks like it's in completely intact and that kind of thing
Gotcha. Now, do
is
you
helpful.
find it's surgeon specific as whether or not they deliver the uterus outside, like
Uh-huh,
exteriorize the
yeah.
uterus for
I've
that
seen
part and for
surgeons
closure? I've seen people that don't do it. It's like an
I
even
don't like
split where I
them
am now,
either.
have to, have don't. And it has a lot to
Exposure is just
do.
so much harder to leave that uterus in, but I have worked with a few surgeons,
Mhm.
John. I've seen a few surgeons that do like to leave it in. In that case, if they're gonna leave the uterus in, you know what's really helpful is an Alexis retractor.
Yes. Yeah, we typically use that on every C-section.
And
It's a game changer, man. It really is.
I like it, and you're right, I like
It
it anyway, even
frees
if you're
it
gonna
frees up your
externalize
hand.
the
Yeah.
uterus,
Yep.
it
And
really keeps things out of the way.
yep.
But it's not a standard where I am. Surgeons don't use it. But if you're gonna leave the uterus in to close it and all that,
Mhm.
that would be really helpful to have that. If they're gonna externalize the uterus after the placenta is delivered, you want to have a damp lap up there
Yep.
on the patient's belly. You're gonna wrap, turban wrap that uterus in that wet lap,
Mhm.
squeezed out wet lap. Gives you traction on it. You can hold it. That way you can hold it straight up. She can see what she needs to see. Clean out the uterus real good. Get rid of any
Mhm.
clots. But they typically want to start closing that uterus immediately.
Oh, yeah, especially if
So
it's hemorrhaging, like, if it's really
yeah, and a lot of
hemorrhaging,
times they'll clamp.
yeah,
You'll see them clamp the edges of that uterine incision with the Penningtons. A lot of times they'll ask for Pennington
mhm.
clamps or
Sponge
rings.
sticks,
I've
like
seen
ring
them use
forceps,
sponge
yeah.
sticks. Yeah, ring
Like, I if
forceps or
it's really
Penningtons are
like, if
most
it's
common.
bad, right, once the baby's out and, like, we're waiting that 1 minute to clamp the
hmm
cord, and if it's really bleeding heavy, I'll just take a ring forcep or a Pennington and I'll
Oh,
clamp
and
it.
clamp it because it can
Yeah,
really
because
be
you can lose a
bleeding.
lot
Yeah,
of
you
blood
could be in a
quickly there.
vessel. Yeah.
I mean,
hmm
they do lose a lot of fluid between the amniotic fluid and their own blood. It's significant. So, yeah.
Right.
So, but it's
Yeah.
not often that I have to do that. So, but yes, I do the same
But
thing.
again,
I'll
something we can be looking out for,
right.
something you can kind of be watching for.
Yep. And then I'll do the same thing. I'll wrap the uterus in that turban and then I'll
hmm
hold it and expose it in a way that they can see what they need to see. But I'll also
hmm
periodically I'll squeeze it too as the surgeon's closing,
You need to be assessing. I'm glad you
because I
brought
want
that
to
up. You
feel
need
the
to be
tone.
assessing the tone of that uterus for
Yep.
sure. And you need this. Listen, the surgeon doesn't have her hands on it, and I all the time have to let the surgeon know this uterus is boggy. We call it. I don't say
Yep.
atonic, but atonic is the correct medical term.
True.
But I'll call it boggy. I'll say
That's
she's
what I'll
boggy
usually
and she's
say
not
too.
firming up.
Yeah.
So, I will try to massage it because that can help firm it, help the tone. The uterus kind of responds to your massaging and says, "Oh, I need to firm up." And we want that uterus to firm up.
Hmm.
But yeah, no, it's communication is key here. You've got
Yeah.
to let them know what you're feeling. Like this is boggy, it's not. And so many,
Hmm.
many times she'll order Methergen based on what I've told her about the uterus, or she'll feel it herself. A lot of times they know. I mean, the surgeons I work with know that I know what I'm very experienced in that area,
Okay.
and so they just listen. So they'll order Methergen
Okay.
if I'm expressing any concern about the uterus not toning up, not firming up. So good point. Glad you brought that up. So
Hmm.
something to know there.
Yep.
You're doing that, and it's okay to get both hands and tell her, I'm gonna get both hands on that uterus and try to give it a massage or just communicate to the surgeon how it feels for
Exactly,
sure.
because that fundal pressure helps the uterus,
Mhm.
regain its tone. So after the baby's
Mhm.
out,
And if they give the Methergen,
mhm.
then I'm assessing, is it working? Is the uterus getting more tone to it? And I can tell the surgeon that like it's getting better. And we can see
Right.
a lot of times they don't worry so much about the tone or lack of tone of the uterus if bleeding is
It's
not
bleeding, yeah.
excessive.
Right.
So we worry more if it's boggy
And
and there's a
bleeding,
lot of
yeah.
bleeding, but you still want that uterus to be firming up. And if you give it a fair amount of time, it should. I mean, they're given pitocin
Right, once the
anyway in
baby's
the
out, they'll
IV.
be
They've
given
added
Pitressin, yeah.
pitocin to to help with that. That's the natural hormone that
Mhm.
our bodies
The
create anyways right after delivery. But
and
they'll
coitus.
add pitocin to the bag. So that Pitocin should help, but sometimes it's not enough. So that uterus doesn't want, and I will say this, that as if you have a patient, John, that's been laboring for an extended amount of time,
Mhm.
that's more likely to happen that uterus doesn't want to. It's just tired.
Oh,
It's
yeah.
just
Okay.
tired. Especially if they were induced. If they were in induced labor and they labored and labored and labored and they just didn't deliver the baby, it's more it's more apt to not want to tone up after delivery. Just something to know.
Oh, okay.
So that's kind of something you can know in the background of the patient and in their history and what she's gone through.
Mhm.
You can kind of know, okay, I'm going to be aware of that because
Okay.
they can have their postpartum bleeding can be increased if they were in labor for a long time. Because that uterus was like, I ain't doing no more.
Yeah.
I'm done. I'm not
So
going to
then
contract anymore.
okay, so then
And
they
that's when we
remove
need
the
Methergen or Cytotec or something else to
gotcha.
help
So they
help that
remove the
uterus clam down.
uterus manually or remove the placenta manually.
Mhm.
Usually take a wet lap, some docs like a dry lap, and then just
Mhm.
sweep out the inside of the uterine cavity, and then we start the closure.
Yep.
So typically where I'm at, most doctors do a two-layer closure on the uterus. Some do a
Mhm.
single layer
Very.
closure.
Yeah.
But at this time, once they start that closure is when you start the first count. So the tech and the nurse should be doing the first count.
Correct.
And then that's where, if the tech was helping me with something like holding a retractor or something, that's typically where I have to take over for that part too, because
Mhm.
doing the count is most important, obviously.
Yeah, they're closing
So
that cavity, that uterine cavity, and so typically that is a soft count only. That's laps and sharps. They're going to count.
oh, really? Okay.
Mhm.
So
Mhm.
we usually counted
So on that
everything, but
uterine
okay.
closure, on the uterine closure, it should be laps and needles are
Oh,
going to
okay.
be
Well, we count
counted.
instruments too
Mhm.
because you can lose an instrument in there too. It's if it's big enough. But that's hospital specific and policy specific
Mhm. It
at
is.
each
It is.
institution. So typically
Yeah, because you're gonna count instruments, yeah.
most of
Typically, so
them.
in my yeah, it's soft, it's laps and sharps on uterus, full count on fascia, and laps and sharps again on skin. So 3
Oh,
counts.
okay. 4 counts. 4 counts for a hysterectomy for a C-section. So you have the uterus, the abdomen, sub-Q, and then skin. Or, oh, excuse me. You have the initial count. Then you have the count when you close the uterus. Then the count when you
Oh,
close
well,
the
yeah, the
abdomen,
initial count,
and
I
the
don't
final
count,
count.
yeah.
Yeah.
Yeah,
So,
right.
yeah,
That's right. I
I
was
missed
talking
on
about a
that one
closing
too.
count, yeah.
So, and it's
So,
typically
yeah.
done in a running interlocked fashion. So you use most people are using zero vicryl or number one vicryl,
Mhm.
and they'll tie it on the uterine angle on my side for the hysterotomy, and then run it towards
Mhm.
themselves because it's easier to suture towards yourself rather
Mhm.
than away from yourself. And then it'll be an interlocking stitch. So then, usually with one hand, I'm holding the uterus and tilting it to present that hysterotomy to them so they can do it.
Mhm.
And then with the other hand, I'm manipulating the suture. So if they're using, most everybody does it continuously interlocked, but
Right.
and then there's a way you can present that suture. So every time they can just grab their needle, they don't have to
Mhm.
sneak around back
They
through the
don't have to
loop and grab
finagle
it.
it, yeah.
So, but sometimes that's
Right.
difficult with one hand, but you can do it. And then they'll run
Yep.
it all the way across,
Mhm.
and then they'll close the second layer.
Mhm.
Typically, that's not interlocked, but some doctors only
Right.
do one
That's
layer
right.
and they don't
Mhm.
interlock the first layer. But then
Mhm.
after they put that second layer in, or if the first layer is done, then we just check for hemostasis. Get
Correct. Well, you
hemostasis,
really
then
wanna
we,
look at that suture line on
yeah,
the uterus for sure.
exactly. Then if we're doing a tubal ligation or not, we usually do it at that point if they want
Mhm.
sterilization, and then we irrigate behind the uterus, um, suck out all the fluid,
Yeah,
make sure
check the
there's no
gutters,
active
yeah.
bleeding. There's
Mhm.
no residual blood, and we've taken all the fluid out. Redeliver the uterus
Yeah.
back inside, so reduce the uterus back inside, and
Mhm.
quick check again for hemostasis. Some
Mhm.
doctors will put Avitine on the bladder flap. Some will use Intercede. Some will use Seprafilm, or a lot of them don't use anything. And then it's the reverse on the way out. So some doctors don't close the peritoneum,
Right.
but typically most of them do. Some don't close
Yeah.
the muscle, but a lot of them do. And they only put one
Mhm.
or two interrupted stitches in the muscle. They
Correct.
don't,
Right.
they don't tie it
And the
super
peritoneum
tight.
too, that's
You're
usually
just
a running, but
reapproximating that. Yeah.
just kinda getting that. Mhm.
It does help though when you're coming back for a repeat C-section if they do close it
Correct,
in
it
layers, in
does.
discrete
It
layers like the
does.
peritoneum, the muscle, the fascia. Yeah.
Mhm. Mhm.
And then it's the
So
fascia.
a lot of times you'll see that on first babies. If it's their first baby, they'll
Mhm.
go ahead and close all that, yeah.
Yeah. So then it's closing the fascia, and typically the surgeon usually starts closing, but it depends. If they let you close half of the incision, then it'll be
Mhm.
the opposite of what you opened. You'll just start
Mhm.
you usually put a coker at the apex of your fascial incision and then start behind your angle. So you want to start behind where the actual incision is and tie that
Right.
and then run it,
Mhm.
take the coker off, and then, some doctors interlock the first one. I always interlock the first suture,
Yeah.
but just run continuously the rest. Some will do
Mhm.
continuous locking, some will do just continuous and lock the first stitch, some won't even lock the first stitch. And then I just run
Mhm.
towards the midline. And if I'm the first person closing, then I'll run towards the midline and tie it. And if I'm the second person closing, meaning the doctor started on my side, ran to the midline, tied hers, then I'll run to the midline and then tie mine, but I'll go a few past hers.
Past
So
hers,
I'll go
yeah.
past her
Mhm.
knot and tie on the other side of it. So it's a
Right.
continuous suture line. There's not a gap in between or a little hiatus, no
Right.
matter how small, in between the two
Right.
suture lines.
Mhm.
And I'll check for hemostasis again. And then that's usually when the doc leaves and we do the rest.
Yep.
So close
Mhm.
subcutaneous tissue if they're fat enough, or if they're
If
corpulent
they've got
enough.
enough and
Right.
and
They have
a
enough
lot of
sub-Q
and you wanna
tissue.
well, sometimes if there's enough sub-Q, it's coming together okay. So if
Yeah,
it's
true.
it's a if their sub-Q is approximated, there's really not a reason to do the sub-Q. You wanna look for those that like, it's gapped, you know?
Right, or there's
I
a dead
mean,
space, yeah,
we all know that. We don't want a seroma. You do not want a seroma in a and I say
no,
when in doubt, just pop a couple stitches in. Pop a couple of interrupteds in, even if you think, does it
yeah.
need it? Just go ahead and put a few in
I usually
because
do to
you
just
do
to
not
line
want a
up the
seroma.
incision
That's
so
gonna
it's easier for
result
me
in
to
a
close.
it's just gonna result in an infection, and you don't want that at a C-section, and you gotta think of
No,
the mom who's got a newborn at home, and she don't wanna be dealing with an infected C-section
right,
incision, so yeah, and then usually a 3O or 4O
mhm,
monocryl, is what is used. Most of the time we use Dermabond. I do work with a surgeon that hates Dermabond. She says that she's seen too many skin reactions from it. She
okay.
does not like it. So we don't use Dermabond on her patients.
Oh, okay.
I actually don't even put Steri-Strips unless it's well indicated, like unless I feel like the incision needs Steri-Strips for
Mm,
support. I close it with a 4O monocryl, and then we put a Mepilex or silver dressing on it, and
okay. Yeah,
that
it's,
works good.
typically it's a caveat for yours and my situation both, is what surgeon preference is, what's on the
Mhm.
card. I ask them, "What do you want for a dressing?" If they say, "I don't care, do whatever you want," then I do what's needed. If it's
Right.
Pernio or if it's Steri-Strips or if it's Dermabond or if
Mhm.
it's a Pico, sometimes a lot of patients, if they're overweight and they have a pannus, especially if their
A
pannus is
Pico
gonna
is a
flop, like,
great,
if you have to use
great
that
thing to use in
if
those.
you've
Yep.
had to use that retractor to keep their pannus out of the way, once you take that thing off, it's gonna flop over the incision. That is
Mhm.
ripe for infection. So, yeah, it
Yes, it
gets a
is.
pico no matter what, in my
Yeah.
opinion. A lot of
Mhm.
surgeons that I work with put a pico on all the time regardless.
All the
So,
time. Yeah.
if that's what they do, then I do that. Now, I did work with one surgeon. She liked to do Dermabond and a pico, but she'd skip the Dermabond across. She didn't, like, lay a line of Dermabond across the entire incision like normal. She would just put dots of it across there. It could, draw through. I put picos over Dermabond before. I talked to the rep, they said it was fine, so but she just skipped it and put it across there, so I just did that's what she wants, that's what she did. I don't argue, I just do what they want, and then, yeah, whatever the dressing, some like a pressure dressing, so that's 4 by 4s ABD and elastoplast tape if they need if they want pressure, and then, typically, everything's done, counts are good, you undrape the patient. There's usually gonna be fluid everywhere. I always wear big, tall boots on these cases because I don't want stuff running into my shoe, and then, typically, I don't do it because I don't feel comfortable doing it, I don't have a lot of experience doing it, is the fundal pressure and expressing the clots afterwards. So, usually the OB nurses will take care of that or the tech even, because it's usually another OB nurse that they've trained to scrub it, or it's a dedicated tech that works in that department. I've had to do it before and I do it, but I don't have a lot of experience at it and I don't do it, so
Right. Okay,
and
yeah.
then
Something, and when we do that, we're assessing the level of the uterus as related to the umbilicus, and
mhm,
also assessing the firmness, the tone of the uterus. So I want to feel a hard ball. We tell patients to feel, and it should feel like a grapefruit is under
mhm,
there, a firm grapefruit. And so, but also you frog leg the patient when you're doing it, and
yes,
as you're massaging the uterus, you're watching it. Are there clots? Is there liquid blood coming out? Is it in excess? Does it stop as you massage after just a few seconds of massaging? Once you get some clots out and bleeding out, does it slow down? You want it to slow down and stop. If it doesn't, that's something to report to the RN or the surgeon and say, hey, this needs to check. Like,
mhm,
they're boggy. What you want a firm uterus, and you want it to be not higher than the umbilicus. So
okay,
the fundus of that uterus should be at the belly button or below. And you
okay,
measure it by
there you go,
finger widths, just by virtue of teaching a little something here by finger widths. So if the top of the uterus is two of my finger widths below their belly button, I say
mhm.
it's two below. If
Oh,
it's
okay,
one below. If it's at the umbilicus. It's just a matter of kind of reporting that to the labor nurse, the nurse that's going to recover her, so that they kind of know. But something for you to know too.
sure,
That's what we're assessing: the feel of the uterus, the bleeding, and where the uterus is located in that belly. So yeah, then we get the patient cleaned up. We place a peri pad after we get their bottom
mhm,
cleaned up. Place peri pads and get them moved over to the bed for transfer out of the OR. and we've just had a birthday party, and it's fun. Most of the time, it's fun.
Oh, it's yeah, I love it. It's like
Most of the
when
time,
it's
it's exciting,
stressful.
yeah.
So,
Mhm. It can
but
be stressful.
a few caveats I would give people, like when you typically in my routine and doing C-sections, they bring the patient usually where I am, they walk the patient in and put them on the table unless they're unable to do that.
Mhm.
Dad stays outside until we're ready to begin. I usually hold the patient for the spinal and talk them through the spinal,
Correct.
trying to get them in good position. Then when we lay
Mhm.
them back on the OR table, we always put a bump under their right side. And that's to take the pressure off the inferior vena cava with the baby laying on the
Mhm.
inferior vena cava.
Mhm.
Put a bump under their right side so it offsets the baby off the vena cava and pressure their vena cava. And do the case. And I'm always mindful of what I say to the surgeon and how loud I say it to the surgeon because a lot of those moms are they don't miss a thing because they are so nervous. They are listening for
Yeah.
every word. They want to make sure
Correct.
everything's okay, nothing's going wrong. So in
Mhm.
those cases, I don't joke around about anything. And if I have
Right.
to say
Yeah.
something that's serious, I whisper it to the surgeon. I'll
Mhm.
lean in and whisper it to her. But because, if mom hears it, and they will hear it, if they don't understand the
Mhm.
context, they could freak out. So, but I usually let the surgeon do all the communicating with mom and then the neonate team or whoever's receiving the baby. The only time I talk to mom is to tell her that I'm gonna push on the baby, push on her belly button or push on her belly to
Right.
help the baby come out.
Mhm.
And then I'll usually just compliment them on how beautiful the baby is or something or
Uh-huh. Of
congratulate them. But,
course.
yeah, that's pretty much it. I mean, those
Yeah.
the highlights are when they go fast, they go fast.
Mhm.
Um, but when they're routine, they're fantastic and they're fun cases to
Right.
do. So,
Yeah.
but that's really all the caveats. I don't have a ton of experience at C-sections. I have some, not like obviously not like
Mhm.
you, but yeah. Would you have anything
Yeah.
you would add to that? Any caveats that
No,
you
I mean, I
do
think we
or
we were thorough. We covered everything. No, I what you just gave excellent advice, just really watching what you say. Don't, it's not a time to make jokes because even in scheduled C-sections, like even if it's a first-time mom and it's a breech baby and we're
Mhm,
in a scheduled situation, it's not a urgent situation. They're nervous and
right,
they are scared. And also it's the birth of their first baby. I mean, there's a lot going on in her
right.
her mind and emotionally and hormonally and all these things. So, um just being careful about what you say. That was good advice. Just knowing that she's not asleep. She can hear everything that's going on. So,
All right. Are
yeah.
wickedly in tune to what's going on. I mean, if
Mhm.
that kid misses a breath or a cry, they're like, "Is he okay? Is the baby okay?"
Yeah.
So which is, good, and you expect that. But yeah, so I don't even because I don't want anything to be mistaken or taken out of context and
Right.
cause the mom any anguish because that's a
Right.
very, very physiologically, they're in a very vulnerable state,
That's
you know.
true. That is true. That's
So
true. And just being
yeah.
sensitive to that. And so a lot of times when I'm standing there whole in front of them for the spinal, I like to encourage them. And you kind of gauge off their energy too. But I'll encourage them and say that everything that's happening now is normal.
Right.
This is all normal. This is all expected. And I say it in a very flat toned voice, like just everything is fine. This is all expected. Nothing is taking me by surprise right now. This is all normal. Like if they're having to try and try and try for the spinal.
Mhm.
Sometimes it's
Oh,
hard to get
right.
those spinals in, and they have to stick and stick
Yeah,
and
because they
stick. The
can't really get
patient's
into
freaking out.
position because they got a big beach ball on their belly,
Yeah.
so
And so just communicating with the patient and staying calm and trying to keep them calm is important.
and one
But
to tell them when we do the spinal is and they always wanna know because it's human nature, and I would wanna know too, is are they gonna have any pain?
right.
And I tell them, "Listen, you're gonna feel your legs start to get warm. They're gonna get heavy. It's gonna take time to set up." I said, "But we are not going to start until you are numb."
Yes.
And I was
That's
like,
another
"You will
thing that's
feel pulling, pushing, tugging, and touch, but you won't
mhm.
feel any pain. If you
You
do
should
feel
not.
pain,
Yep.
you tell us, we'll stop,
Right.
and we'll fix it right then
And
and
we'll
there."
figure it out.
And
Mhm.
that kind of reassures them because they're afraid of, like, you thinking they're anesthetized and then cutting them, and they're in excruciating
They
pain.
are.
So,
That's a
you
very
know,
common fear, yeah.
we
So
always do a skin test before we make the initial incision. So we take a grasper or a
yep.
coker. I usually take a pair of pickups and just squeeze, and I don't let them know I'm doing it. I
I
just
take
squeeze
Bonnies.
and
I
then
usually
I
use
listen.
Bonnies.
I don't tell them, "Hey, do you feel this?" Because patients might
No,
say,
they'll make
"Oh,
it
yeah,
up.
I do," you know? And
Mhm.
like I said, they're gonna feel touch, they just won't feel pain, so that's why don't
Mhm.
I do it sometimes the surgeon does it, I typically do it, and I don't tell them I'm doing it because I'll hear it if they feel it because it hurts,
Mhm.
but if it doesn't,
Mhm.
then we're good to go, and then that's
Right.
when we start,
Right.
so but typically
Yeah.
that's my disclaimer I give everybody that I hold for a spinal is I tell them what to
Yeah.
expect, and then if you feel any pain, you just tell us, and we'll stop and fix it right then and there, so but and
Yeah.
that usually, reassures them, and that's pretty much
Yeah.
it. Um
Yeah. Yeah. So that's C-section. So if you have any comments or anything to add, anything you want to share with us about any C-section experiences you have, that would be great. We want to hear about it.
Mm.
We all have good stories, and I
What's
like to hear
the,
stories, especially if
the the most babies you've delivered at one time via C-section? Mine's only
Oh, I was
twins.
gonna say that, just triplets. I think I've just
Oh,
done triplets. I
triplets?
don't
That's
think I've
cool.
done quadruplets. I think we had quadruplets born at my hospital when I was there, but I can't remember if I delivered them or not, if I helped deliver them, but I know I've done triplets.
Oh, cool.
So, I think triplets, I'm gonna go with that as the most babies I've delivered, yeah.
Did they each have their own amniotic sac, or were they in one
Um,
sac?
no, monoamniotic would be really I have delivered mono I mean, they did each I'm sorry, they did each have monoamniotic is rare, and I have seen
Oh.
monoamniotic twins
Oh,
where
have
they were
you?
both in one yolk sac, yeah.
Mm.
That's not common, that's cool to see the both babies in one amniotic sac is really cool, but yes, the triplets were all on their own, yeah, mhm.
Oh, cool.
All
Yeah.
on their
So if
own.
you
It's been many years ago,
can
though, I
leave that in
haven't
the
done that.
comments of what's the most babies you've delivered
Yeah,
by C-section if you're a surgical assistant.
yeah, yeah, for
So,
sure. That'd be cool. All
yep.
right, that wraps up another one, John.
Yes. Well, thanks for joining us. We look forward to seeing you on the next episode.
Yep.
And we got some pretty interesting ones coming up. So,
Yes.
yeah, don't forget to like, comment, and subscribe. Any future ideas you want us to cover, just put in the comment section or, be sure to join us on the next one. So, everybody have a
Yeah.
wonderful night, and we'll see you on the next one
Yep. Bye,
or day,
everybody. See
depending
you
on when
next
you're
time.
listening to
Or
this.
day.
Mhm.
That's right.
So, all right. Take care.
Bye.
So
Thanks for listening today. We invite you to like and subscribe to this channel and leave a comment if you'd like. Feel free to look us up on Facebook at the Surgical Assistant Podcast or email us at thesurgicalassistantpodcast@gmail.com. Until next time. Content of this podcast is in no way intended for diagnosing or treating surgical conditions. No patient-specific information is shared, and all HIPAA guidelines will be adhered to.